Good evening, and welcome to AUA's Overactive Bladder Update 2024 Expert Guidance for APPs live virtual course. We strive to offer outstanding educational courses and greatly appreciate your evaluations and general feedback so that we can continuously improve our programs. The AUA is accredited by the ACCME and designates this live activity for a maximum of 1.0 AMA PRA Category 1 credits. Course handouts from the presentation have been made available to you. Please visit AUA University to access the handouts. Evaluations are very important to us. Course evaluations and CME credit will be administered electronically on AUA University immediately following the course. As we at the AUA continue to develop virtual education that meets your needs, we especially welcome your feedback regarding both the content and format following this program. All persons in a position to control the content of a CME activity are required to disclose to the AUA, as the ACCME accredited provider, all financial relationships with any ineligible companies, formerly commercial interests, during the previous 24 months. An ineligible company is defined as one whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. The AUA must determine if the individual's relationships are relevant to the educational content and mitigate any conflict of interest prior to the commencement of the educational activity. The intent of this disclosure is not to prevent individuals with relevant financial relationships from participating, but rather to provide learners with information so that they can make their own judgments. Coding advice given during presentations are the opinion of the presenters and may not have been vetted through the AUA for accuracy. Please verify accuracy prior to reporting on medical claims. You are prohibited from using or uploading content you access through this activity into external applications, bots, softwares, or websites, including those using artificial intelligence technologies and infrastructure, including deep learning, machine learning, and large language models and generative AI. The AUA would like to thank Sumitomo Pharma America, Inc. for providing an educational grant in support of these activities. Finally, I'd like to introduce and extend a special thank you to our course director, Ms. Kathleen Scott, for her time, talent, and expertise in developing this program. Kathleen is a physician assistant at Cleveland Clinic Glickman Neurological and Kidney Institute. With a focus in female urology, this dedicated professional exemplifies commitment through her involvement in SUFU and a keen interest in enhancing APP education. She is an active member of the CCF Urology APP Shared Governance Group and ACGME Urogynecology and Reconstructive Pelvic Surgery CCF Fellowship Clinical Competency Committee. She is committed to providing world-class care while connecting her patients when discussing difficult topics such as incontinence, UTI prevention, pelvic pain, and pelvic organ prolapse. I will now turn the course over to Ms. Scott.
Thank you. All right, based on the documented need from the AUA, OAB Needs Assessment, AUA is providing education to update APPs on the latest advancement in OAB treatment. Our learning objectives are below, so looking through them quickly, we're just looking to adjust methods for diagnosis and treatment of overactive bladder based on the new 2024 guidelines, analyze indications, mechanism actions, and dosing regimens, educating patients on what to expect and utilizing appropriate tools, and then effectively documenting medical necessity for beta-3 agonists and other OAB medications to insurance providers. Okay. Is everyone here with us? I want to welcome everyone and say thank you for attending. We have an amazing panel here. And we have an amazing panel here, and we want this to be as interactive and informative. So please ask questions in the chat. It is not every day you get to have these experts right in front of you. So without further ado, it is my pleasure to introduce our subject matter experts joining us this evening. Victor Nitti is a professor of urology and obstetrics and gynecology at the David Geffen School of Medicine at UCLA. He is also the fellowship director for that ACGME accredited program. He is a graduate of Rutgers University, New Jersey Medical School, and did his urology residency at SUNY Downstate in Brooklyn, New York. He then completed a fellowship in female urology, neurourology, and reconstructive urology at UCLA. Michael Gray is a professor in the School of Medicine, Department of Urology, and School of Nursing at the University of Virginia in Charlottesville. He is editor-in-chief of the Journal of Wound, Ostomy, and Continence Nursing. He has lectured both nationally and internationally on topics related to neurological urology and urodynamic testing. Suzanne Smith is a physician assistant at Southern Urogynecology in Columbia, South Carolina. She has been working in the field of urogynecology with a special emphasis on overactive bladder treatment and management for nearly 15 years. She graduated from the University of North Carolina, Chapel Hill, and then attended Wake Forest University PA program, graduating in 2000. Right. And let me see the screen. All right. All right, let's get started. As we know, the AUA and SUFU recently released the updated 2024 guideline on the diagnosis and treatment of idiopathic overactive bladder. Dr. Nitti, what can you highlight in terms of most interesting or notable features of this guideline?
Well, first of all, thank you, Kathleen, and I want to thank the AUA for this invitation. I think that the most significant changes really are that there is more of an emphasis on types of therapy, and the idea of lines of therapy has been eliminated. So rather than thinking in terms of, okay, first line therapy is behavioral, second line therapy is pharmacologic, now the therapies are lumped into their appropriate categories: management strategies and behavioral therapies, non-invasive therapies, pharmacotherapy, minimally invasive therapies, invasive therapies. So it may be appropriate in certain patients to go right to a higher level, or what we used to be considered a higher level of therapy. And this is all based on a shared decision-making model. So there's much more emphasis on shared decision-making. The best way that I can highlight that is if you have a patient who does not want to take, for example, an anticholinergic agent because they're concerned about side effects, it is perfectly reasonable to offer minimally invasive therapy as the next step, or backtrack to behavioral therapies or to pelvic floor physical therapy. So the emphasis is off of lines of therapy and more on, okay, here's the different strategies we have to manage your condition. What's going to work best for you given the pros and cons of each? And I think that's very important. A couple of other minor things or other things. One is that telemedicine is now part of the guideline and does give guidance on treating patients with overactive bladder with telemedicine. And another thing is that the male patients who have also may have an element of benign prostatic enlargement or obstruction, overactive bladder is included for those patients as well in this guideline, where it wasn't really mentioned so much before.
Right, exactly. And Dr. Gray, has the kind of elimination of the terms and the strategy, you know, like as Dr. Nitty mentioned, of first, second, and third line, the stepwise, and instead shifting to a focus of, you know, invasiveness as well as shared decision making, does that change your practice at all?
You know, it really has. I think it's changed my practice less philosophically than it has encouraged me that the idea of first, second, and third line therapies is appropriate in some ways, but actually a little bit restrictive rather than opening up possibilities of therapy. I thought that Dr. Nitty brought up a really nice point about the patient who has, for example, who just simply does not want to take a certain, use pharmacotherapy, would like to go with something like what would formerly have been called a third line therapy.
Mm-hmm.
I also think that I'm going to be anxious to see the insurance providers and the various things that we all have to deal with. I want to be anxious to see them come along with this. My practice is perhaps a little bit different than perhaps some other APPs, but I'll give you one perfect example. When I'm doing things like one therapy that I often turn to is percutaneous tibial nerve stimulation. I'm when I'm with patients during those initial 12 weeks, I'm spending a good deal of time going back to behavioral therapies or really re-emphasizing behavioral therapies. And I find that those therapies used in combination with PTNS or whatever my current main therapeutic approach may be is very helpful.
I agree. And, you know, with the different terminology and changes in terminology, it's hard because we've always said third line, and now we're saying more regarding minimally invasive and kind of the invasiveness. But despite all the terminology in my mind, you know, I'm still going down kind of the OAB treatment algorithm, which we often call the OAB care pathway. And it can be a lot of info for us to explain as well as for kind of patients just to take in. Suzanne, do you utilize anything to aid in patients' understanding?
Absolutely. I mean, I think, Kathleen, what we've been saying all along is this new algorithm is sort of giving us some fluidity to customize treatment for patients, which we've pretty much been doing in our heads already, but allowing us some freedom to kind of move through back and forth through this pathway. I find that with my patients, when we see them as a new patient, we are going over so much information. And you know that look, that deer in the headlight look, they are overwhelmed. They have like sensory overload. They have lost you. And I use a patient care pathway, a printed out one, and you can use your own or you can use the one that's provided from the AUA, but some sort of visual tool to help patients sort of track where they've been, where they're going. And I find that the tools and that visual tool really helps patients see the journey they're on, where they've been and where they're going, and gives them some hope that there's lots of options ahead for them. This is not the end of the road. This is the beginning of the road. And this is a map up for the journey.
You know,
Exactly.
my biggest hope for the new guidelines are that third-party payers pay attention to this so that it's not just us recommending, but they will allow patients to skip second line therapy and go to, or skip pharmacotherapy and go to minimally invasive therapy without a big to-do. I think that's going to be hopefully the biggest benefit of the new guideline.
I think it's going to be
Agreed.
great.
And this
I
has
really
already
think
been mentioned in the chat just about insurance covering, which is a huge hot topic for all of us.
absolutely.
All right. Dr. Gray, do you use the any paper OAB pathway?
We do use it, as a matter of fact. Again, I'm a bit of the second line referral source for some of these things because I'm specializing in some of the more
Right.
some of those therapies. I think the thing that I really want to emphasize on, I love the fact that Dr. Nitty brought this up, is my patients crave fluidity. And as APPs, I think that we are always very well strategized to say, okay, even though we're at this point, I'm looking over perhaps your sacral neuromodulation device or whatever it might be, I want to go back to the basics. Let's talk about bladder irritants. Let's talk about caffeine. Where are we at with caffeine? Where are you at with your fluid intake?
Mm-hmm.
And I think that sometimes going back and just, again, I don't want to analogize it as identical, but it's even with things like IC, interstitial cystitis, painful bladder syndrome, my patients, I spend a lot of time saying we may be using several interventions at once. And I believe the new guideline allows for that fluidity so that we can say, we're going to look at behavioral things. We're going to look at pharmacotherapy. We're going to look at, previous third line. I'm going to get better with my use of that language as I get more used to things.
We totally understand.
but we're going to look at using multimodal interventions appropriate to our patients. We're going to look at individualizing that. And I love this idea of fluidity between the management options.
I know. All right. So next, we're going to the next slide, and we will discuss pharmacotherapy and the medications we use to treat idiopathic overactive bladder. So there are two classes of medications. First is anticholinergics, and they are also called antimuscarinics. And the second is beta-3 androgenetic receptor agonists, which we also call beta-3 agonists or simply beta-3s. Dr. Nitty, can you please describe the indications, mechanism, actions, and summarize kind of the dosing regimen for anticholinergics and beta-3s?
Sure. So I like, and my patients ask me this all the time, and there are two distinct mechanisms of action. Anticholinergics or antimuscarinics block the muscarinic receptor. When the muscarinic receptor is stimulated, it causes the bladder to contract. So think of it as blocking contraction of the bladder and hopefully mostly blocking unwanted contraction of the bladder. Beta-3 agonists, on the other hand, promote relaxation of the bladder. So as a beta-3 agonist is giving, it promotes relaxation rather than stopping contraction. Now, the nice thing about it is that because there are two different mechanisms of action, it means different side effects, but you also have the option to combine the two in certain instances. Dosing regimens, both of the beta-3 agonists are extended release formulations. So they are meant to be taken once a day. Mirabegron comes in 2 doses, 25 and 50 milligrams, and Vibegron in just 1 dose. Antimuscarinics have immediate release formulations, at least most of them do, and extended release formulations. Immediate release formulations are nice when you want a very limited window of therapeutic action, but they also have higher side effects because more instantaneous peak blood levels and then a trough, and then a peak and a trough, whereas extended release keeps a more constant amount in the bloodstream. So for chronic use, extended release medications are really preferred as they tend to have less side effects.
Sure. And, we've already kind of touched on the imperativeness of shared decision-making and discussing treatment goals and the kind of the fluidity of the OAB care pathway and helping patients make an informed decision. Dr. Gray, do you find yourself typically when do you find yourself typically starting a medication?
So again, a lot of it's going to depend on shared decision-making with the patient. I will say comfortably that the majority of patients that I interact with want to hear about behavioral issues, but at the same time, they want to do something above simply something that they could perceive. They could go on the internet or go to other sources and just get ideas. So with the majority of my patients, they are going to be interested in starting a medication pretty much up front. And we're going to talk about that. We're going to talk about anticipated effects. We're going to talk about adverse effects, just as was explained by Dr. Nitty previously. And I find that that's going to be, for the majority of my patients, I'm going to combine behavioral interventions. I usually talk about essentially fluids and bladder irritants. I also talk about a little bit about toileting, and I'm going to put those together. I also, by the way, for whatever it's worth, I like to have a bit of a separate conversation with patients about nocturia. I tell them that nocturia is not only something that's interactive with overactive bladder, but there are some separate things. It's almost a condition unto itself. I don't get into too much detail, but I do explain to them about nighttime urine production and quality of sleep, et
Yeah,
cetera, et
that
cetera.
could be a whole nother talk.
Exactly. Absolutely. So that's probably where I'm going to start with the majority of my patients. Now, patients who, again, prefer not to, they're leery because of adverse side effects, then we would, particularly with the new freedom in this new guideline, then we're going to look at other alternative or complementary pathways and proceed down those.
Yeah. Suzanne, is there an example of when you choose an anticholinergic over a beta-3 or vice versa?
Absolutely. And I think like what Dr. Gray was just saying, this is all shared decision making. We're explaining to the patients the pros, the cons of each of these meds and the ideal place to use them. I use my anticholinergics. That'll be my first med for my younger patient, my patient that I know I'm going to have a difficult time getting a beta-3 approved by insurance, and I know I'm going to need to start there, and I'm not as worried about the CNS effects. I'll start with my younger patient on an anticholinergic. I also use anticholinergics with my patients that have fecal incontinence and fecal urgency. We see a tremendous amount of FI in my clinic. And we pick that up on our new patient questionnaire. And so if they've got some dual incontinence, some loose stools, fecal urgency, those patients are a great candidate for an anticholinergic to help kind of form that stool a little bit.
I know you use the bad as the good kind.
I use the bad for the good.
Hopefully,
And
right?
yeah. So, and then for my beta-3s, I'm going to choose that, my patients over 65, where I'm very concerned or more concerned about that, the memory issues, the CNS effects. And if patients may have a little dysfunctional voiding, and I want to be leery of retention that patients may get with anticholinergics. That's another situation where I would choose a beta-3. And then interestingly, I've run into this, between the beta-3s, the vibegron can be crushed. So if you have a patient that can't swallow pills, that is a good option for them. So there's reasons and tips and tricks to try and pick the right medication for the patient.
Got it.
Suzanne, a brief aside on something that you said that I think is really important. Very recently, the AUA has also come up with research-based guidance related to not only anticholinergic use, but also ADT. So let's focus on the antimuscarinic use for this moment. And I think it really offers some idea about again, adverse effects, including possible cognitive and command function adverse side effects. That's kind of brand new. So I'll just throw that in as a little plug. I just got exposure to that document. I think it's very nice complement to the new guidelines.
Yes.
All right. Before we move on, we just got a question on the chat. How do you decide which antimuscarinic to start with when they are all within the same class? I find myself picking between the same three just by choice of MD preference. I would like some background on the best to choose first.
I typically start with fesoterodine because it has less of the blood-brain barrier exposure, and it has reduced CNS effects. So I usually start with that one. And the other, aside to fesoterodine, you can hopefully get it approved by their primary commercial insurance, but that's now available on third-party insurances like Mark Cuban's, and you can get it very inexpensively.
Mm-hmm. Dr. Nitti, are you using the same?
No, my preference to start would be trospium because trospium, at least in healthy patients, trospium doesn't cross the blood-brain barrier. The problem with trospium is it's a little bit more challenging to take because the immediate release or the twice daily trospium is the one that's readily available for a reasonable price. Extended release trospium is not made by many generic companies. You also have to take it on an empty stomach.
Mhm.
So those are the barriers of trospium, but at least in healthy patients. Now, what the blood-brain barrier looks like in a more frail elderly patient, I don't think anyone really knows. But so my preference would be to start with trospium if the patient can take it on an empty stomach and is willing to take it twice a day.
Okay. And if they don't take it on an empty stomach, do you still feel like it works?
I think it still works, but it just doesn't work. It doesn't work optimally.
Agreed. Okay. All right. I think we've hit. Any recommendations on the best medication for OAB related to BOO or BPH, or in combo with other meds for BPH like Flomax? I know we're a little tight on time, but.
I mean, I can answer that quickly and say there's data on tolterodine, there's data on a number of antimuscarinics that you can combine or use alone. There's also data on mirabegron and vibegron that you can use for patients who have bladder outlet obstruction and overactive bladder. And I combine beta-3 agonists a lot, either combine them with an alpha blocker or use them on their own in patients with bladder outlet obstruction and overactive bladder.
Agreed. Okay, so moving on to the next topic and the next slide. All right. So you've decided to start pharmacotherapy in the care plan for an idiopathic OAB patient. I'm going to start with kind of the negatives first. Dr. Nitty, what do you tell your patients about potential drug adverse reactions, and are there differences between the anticholinergics and the beta-3s?
Definitely differences for sure. I mean, the obvious side effects that you'll see from antimuscarinics are dry mouth and constipation, the two big ones. Blurry vision, dry eyes can also occur. We now know that there's an association with cognitive dysfunction and dementia. I say association because it's not been proven absolutely to be a causal relationship, but there's definitely an association. And a lot of times just that association will make patients a little bit leery. Oh, some patients will complain that they just don't feel right. They're a little bit fuzzy. The beta-3 agonists are fairly side effect free. Now you have to go, if you go to the mirabegron label, it mentions hypertension. I'll tell you that if you look carefully at the studies, hypertension was equivalent in mirabegron as it was in placebo. However, that warning is there. For vibegron, that warning doesn't exist.
That is a great point. And Dr. Gray, what do you tell patients in terms of how quickly the medications should start to take effect, and kind of when you see kind of some hopeful improvement?
That's an excellent question. And it is somewhat dependent on the individual medication. But in general, I have been in practice for a lot of years. And one of the things that I remember was that you would give your patients, some freebies. You'd have your little samples in your office. This is going way back in the day. And you'd give them enough and you'd say, well, hopefully it'll be working by the end of several days or something along these lines. And that was, in my opinion, very destructive and unfair. And I think it's still an unfair thing. I try to encourage my patients, in the absence of adverse side effects, to look at a course of about 4 weeks to really determine efficacy. I'm also working with them on I'm really heavily working with them on behavioral interventions, fluid, irritants, and toileting habits at that time.
Right, and just going back to that fluidity. And Suzanne, what if a patient starts a medication and does experience any of those adverse reactions like that Dr. Nitty mentioned, whether common or not? What do you tell them to do, and how do you have them report this adverse reaction to you?
I think it's really important this is where that education piece comes in play. They need to know what to expect, and you need to set expectations, because if you're going to prescribe an anticholinergic, all likelihood is they will probably have some varying degree of dry mouth, dry eye, constipation, bowel changes. They will most likely. And so if you educate them that that may happen and you advise them to make sure they're eating a high fiber diet, drinking, a recommended amount of water, and that may help alleviate some of those calls. But then
Right.
I do tell them if the symptoms that they're experiencing are difficult for them and they would like to stop the medication or it's become very severe, then I have them call the office. They speak to my medical assistant, or through our Epic system, they can message me and I can
Yes.
advise them whether they should stop. And then I can either change their medication or bring them into the office.
And I feel like a question I get a lot is it okay if I just stop right away, or do I have to wean in any? So I always try to mention that as well when I'm,
Absolutely.
discussing.
Absolutely.
Does anyone else have anything to add to that? All right. So now that we have covered the negatives and adverse reactions of the medications, we will now discuss the positives of medications and hopeful positives and how we assess the efficacy of OAB treatments in clinical practice. Dr. Nitty, do you have any tools or methods you use to define efficacy in overactive bladder treatment?
Well, I do, but it's really simple. So my primary tool in everyday clinical practice is to simply ask the patient, is the medication doing what you want it to do? Is it doing it to a degree that you are happy? Do we not need to do anything further, or do we need to do something further? The reason that works in everyday practice is because each patient with OAB has different treatment goals. For some people, it's frequency. For some, it's urgency. For some, it's incontinence. Might even be nocturia, although we discussed that's multifactorial.
Sure.
So depending on what the goals are, the question that you ask would be different. Now, if there's any doubt, or if, certainly if you're talking about investigating something in a clinical trial situation, then you're going to rely much more on questionnaires. But in everyday practice, I just want to know from the patient, are you better? Are you better enough? Are you having any side effects? And from those three questions, we can determine continue what we're doing, change what we're doing, increase dosage if it's something where you might increase dosage.
Right. And does everyone here, I mean, I love those three questions. Those are perfect in my mind, but does everyone here use like a symptom questionnaire or maybe a bladder or voiding diary?
I use a voiding diary all the time. I get a baseline, but I pull those out all the time when they tell me they're not doing well, or they were doing better 2 months ago, or different things. I think it can become very confusing to patients as they get more remote out from all the things they've tried. They can't even remember where they used to be. So I think bringing back a bladder diary can be really helpful.
I agree.
Yeah, I agree with that too. It's very important in the diagnostic algorithm for a lot of different patients. And I would agree it's important when a patient tells you, yeah, I don't think I'm doing that well. So I think of all the things you can do, a diary, which I think of more as a diagnostic tool, is really important.
I agree.
One of the challenges I face, and I'd love to hear from other panelists too, is my patients tend to have a very vivid memory of the last embarrassing, and I'm going to emphasize embarrassing, urge incontinent episode that they have. I saw a patient this afternoon. She's done extremely well. And when I look at her bladder diary, she's down to 6, 7 urinations a day. And she simply had a moment when she had a bad leakage. And she said, I'm back at ground, zero, and I just don't think I'm better. What do you think? And we had a good discussion about looking at the overall diary, but I'd love to know any insights you have, because my patients have good memories of that last incontinent episode.
Yeah.
I completely agree with that. And yes, I always try to go back and refocusing in the back of my mind, look at the improvement that you're having. This is a chronic condition. We are, we are looking for treatments, unfortunately, not cures. I cannot give you back your teenage bladder, which could hold for hours and hours and hours. And that's one of my huge talk tracks that I always use.
Nice.
These patients are ours, or I have patients that I've been seeing for years So
Mhm.
they forget where they started. So those bladder diaries can be really important. I just saw a lady today as well who her baseline was 12 accidents a day. And today she was so upset because she's having 2 to 3 a day. Well, that's still terrible. You have to kind of track back to remember
Yeah.
what the journey has been.
Yes. And that fluidity, again, like kind of you talked about.
Moving back.
And we kind of already talked about this, because in the back of my mind, I'm always kind of thinking about kind of greater than 50% improvement. But again, that's kind of going away with the discussion and are you happy and how is this going? But Dr. Gray, how do you kind of agree with kind of greater than 50% improvement? Is that efficacy, or do you have kind of another way to look at it?
I look at it on multiple levels. The first thing I want to know is, again, I love Dr. Needy's approach in the sense of, are you better? Is it, are you better enough? You know what I'm saying? Just looking at those two questions in particular. Urogynecology colleague at my place, UVA, is named Dr. Kathy Holfish. And one of the things that she looked at in some of her research that I've found valuable to my practice is, again, what are your goals? And with OAB, we know they could be frequency, could be, could be other things, could be nocturia. And then you have to, again, go on that side pathway that we talked about. But I'm also surprised that many of my patients will set some fairly functional goals that are going to be, I want to be able to get to work without having to stop and, relieve my bladder. I want to be able to drive a certain amount of time. I want to be able to get through my classes or meetings at my work. And so I do like the idea of 50% better globally, which is really what I try to get them to tell me globally. Don't think about one day, one event, think about it globally. But I also very much like to go back. I try to get them to identify their goals when they're really kind of at the bottom, when they're just starting, they've got really severe symptoms. And I go back and I say, well, let's go back and look at this initial goal. And you wanted to be able to get to drive to work without stopping at that terribly not clean restroom, that's the only place that you can get off of the freeway, whatever it works out to be. And I find that my patients sometimes find that very reassuring to say, I hadn't thought about that now that it's happening. So
Right.
Sometimes building a little bit of a story of improvement, I find, is also useful. I think that everybody's comments too about this is a chronic condition is absolutely critical. I tell them I can improve, I will not cure you. And a perfect cure might be not peeing at all. And then you're going to open up a whole new problem. So I do really try to balance that fact about we cannot restore. You said it very nicely, Kathleen. We cannot restore that teenage bladder. We can't take you back to your 20s. Believe you me, I would love to go back to my 20s, a little bit of hair on the top. But irrespective of that, working with my patients about their particular goals, many find that reassuring and individualized type approach.
There's a lot of questions and discussion in the chat about how long do we use voiding diaries? I'm typically a 3-day girl. Anyone else?
I'm a 3-day.
All right.
3.
Okay. And I know this is always a big discussion topic at our weekly urodynamics conference that I am lucky enough to attend at the Cleveland Clinic. But when do you order or perform advanced testing such as urodynamics, cysto, or imaging? Suzanne, can you start us off?
So I think, now the guidelines tell us when there's uncertainty of the diagnosis. And so when things are starting to not fit into the puzzle pieces aren't fitting together, and patients aren't responding to your therapy. So I start considering urodynamics when I have patients that are refractory to medications, maybe 2 medications. Or if there's some mixed incontinence and I'm concerned there may be more of a stress incontinence or a structural issue going on, or if there's possibly some dysfunctional voiding or some obstructive voiding. So when I need a clearer picture of what's going on. And if I'm considering moving towards Botox, that's, I'm going to do a screening cystoscopy. I do a cystoscopy, obviously, for recurrent UTIs and hematuria and those sort of issues. So when the picture is a little bit more complicated than just your run-of-the-mill overactive bladder, that's when I start getting more diagnostic testing.
Dr. Nitti, do you agree or have anything to add?
I'm pretty, I will do urodynamic testing, for example, urodynamic testing in situations mostly when there's emptying issues. And if somebody tells me they're not emptying their bladder well, then a lot of times I'll do a uroflow and a post-void residual. And if there's something not right about those, it may lead me to urodynamics. If there's any reason to suspect that the patient has an issue with bladder compliance, if there's any reason, so radiation, for example, if there's any reason to suspect that there's obstruction. Now that's obvious in men, but in women, sometimes a little less obvious, but often in women, that comes along with voiding symptoms. Other than that, I don't find urodynamics generally changes what I do for patients. And if you look at all of the studies on Botox, on sacral neuromodulation, those were done predominantly, at least the contemporary studies, without the use of urodynamics. So I need a reason to do it. Now, I see a lot of advanced patients, so I do a lot of urodynamics. But for me, I got to have an idea that it's going to change or really impact what I do.
I think that's an important statement. I think that there has to be something that you're looking for and something that will add to the picture and help with the diagnosis and the treatment for the patient.
Yeah, and as Suzanne said, if the diagnosis is unsure or it's a mixed picture and you just can't get it out of the patient comfortably, is this more of a stress or urgency problem? That's a great place to use it as well.
And just also, we see a lot of complex patients as well. And sometimes people are coming to us and they might be coming to APPs too. You have no idea. Make sure you get that good history about, oh yeah, I had that bladder lift and maybe there was a sling 20 years ago and I haven't been peeing the same, that for me is obviously along the emptying issue, but there's so many times when you're so through so many of your questions and, your discussion, and then they're like, bring up that bladder sling they had and so that is also a thing that leads
another thing that's important, and I see my residents trying to be, trying to think ahead, and a new patient will come in and they'll present a uroflow and a post-void residual to me, and I'll say, well, do we have a urine analysis? And they'll say, no. You don't want to forget about this, a simple urine analysis. That's there's not many things in the guidelines for diagnosis, but that's in there. Make sure the patient doesn't have microscopic hematuria predominantly, and then bacteriuria could be associated with symptoms as well.
Yes, and we just got a question in the chat before we end this segment that is very hard. I mean, what may be a clue from history of symptoms or signs that you are questioning compliance of the bladder? I mean, that could be a whole nother talk as well, but.
Well, I would say history of radiation, history of long-term obstruction, history of TB or diseases that are known to cause poor compliance. And then the other thing is symptom. It would be more of an insensate incontinence, or incontinence that's not related to stress or urgency, usually associated with a bit of a residual. And of course, neurologic disease, but that's a whole nother, that's a whole nother.
No, this is idiopathic. Okay. All righty. So going on to segment number 5, our last segment. Ooh. Finally, we will discuss maybe one of the most frustrating parts of my day and maybe career is insurance coverage. Okay, so Dr. Nitti, we've gone down the OAB care pathway. We've handed the patient a piece of paper explaining everything. We've discussed the different treatment categories, including behavioral, non-invasive versus invasive, and also discussed optimizing comorbidities and using shared decision-making. We've decided to start them on a medication. You then discuss the adverse drug reactions and ways to assess the efficacy and when to follow up. And then in about 2 hours, you get a message in your inbox stating that the medication is not covered and it's about $400 for 30 days. Now, what do you do?
Well, then it's a whole nother, you're going to repeat the discussion with the patient. We often do this at the same time, anticipating that might be a problem. We try to get a prior authorization. Oftentimes, we're not successful if the patient hasn't tried other medications. Now, one thing I will tell them, if I prescribe a beta-3 agonist and it's not covered by their insurance, and their insurance requires them to fail or have side effects from an anticholinergic, and sometimes it's 2 anticholinergics, I can give patients relative assurance that if you take an antimuscarinic for less than 3 months, it's unlikely to give any long-term cognitive side effects. And that's in, I know it's in the SUFU white paper. So with that, they can
That's
at least
reassuring.
feel comfortable if they want in trying the medication, trying an antimuscarinic that may have side effects and seeing what happens. Now, the other choice is to go to a different type of therapy.
Right. And hopefully, as we said, with this more fluidity and shared decision-making, that insurance companies will hopefully kind of follow suit with our expert.
And hopefully
guidelines.
we'll have generic
That's it.
beta-3 agonists in the not too distant future.
Yes. And Dr. Gray, do you have any tips or tricks on getting beta-3 agonists covered? Have you had any success in getting them covered?
Yes and no. I will say that it's a frustrating chore to do, but some of the things that we're doing to try to somewhat anticipate this and get ahead of the 8 ball is again careful documentation of previous trials with any muscarinic drugs, delving into and also looking for contraindications, Sjögren's syndrome and glaucoma and these types of things. So we do have a look at comorbid conditions in anticipation of looking at moving forward from anti-muscarinic therapy or simply stepping beyond anti-muscarinic therapy in very specialized cases.
Right.
I certainly admire and continue to admire many of my patients' ingenuity on their own. I obviously talking about, if you're able to, quote, shop around, then it's appropriate to look at various, retail pharmacies, to look at other sources of their drugs. We certainly encourage things like GoodRx, which sometimes has little to no effect, sometimes has a little bit more potent effect. We certainly can look at various retail pharmacies. And again, I'm not going to go into names, but we have a couple of the big membership stores, and I'm sometimes surprised that folks will actually join those membership stores because there's such a significant difference in some of the out-of-pocket drug costs. So these are other things. And again, some of my patients, they're very sophisticated. They have family members who are quite sophisticated, and they're able to quite successfully look for online sources and go to, again, the big, huge jungle companies, so to speak,
Right.
and actually find sources that I was, not aware of.
And sometimes there's promotional or manufacturer-based incentives to help patients get medications. That exists with Vibegron, for example, and it doesn't apply to all patients, but
Exactly.
gosh, it's great when it applies to your patient.
That's so true. And I mean, despite, I feel like, expertise or seniority, in my opinion, you must kind of have a plan and a team in place for getting not only medications, but all types of therapies covered. Suzanne, can you please touch on a little on the success that you've had with that?
Yeah, it's a village. It takes a village. I mean, it is a full-time job to get these treatments authorized for our patients. So, our Cover My Meds is linked to Epic. So it comes right into my medical assistant's work inbox. So she knows right away. I sometimes know before the patient hits the parking lot that medicine was $400. So what we've done in ours is I am putting all of that detail into my note. patient has constipation, patient is over the age of 65, patient, whatever I'm trying to get authorized, I make sure all those details are in my notes so that my medical assistant can just click those boxes on the cover of my meds to help get these medicines authorized. We've had a little bit of luck getting, Mirabetriq now that has a generic option covered. It's been sort of hit or miss. Sometimes we're getting it covered. Sometimes it's been a little tricky. I have hopes that January, maybe things will get a little bit easier with that. We, like Dr. Gray said, we use a lot of different resources. We're using Mark Cuban. We're using industry coupons for commercial insurance. Obviously can't use those for Medicare patients, unfortunately. And they have the ones with the worst medication coverage of all. So just trying to find different tips and tricks, but ultimately this is why the new guidelines are so wonderful and going to be so much more effective, because we're going to be able to fluidly move through these guidelines when we hit these roadblocks of we can't get the medicines covered. And if a patient's medicine is $400 a month and they can't fill it, it does no good to any of us. So it really gives us that option to circle back and move on to more of our minimally invasive therapies.
And I think you hit a great point about just proper documentation and then others in your team. It doesn't have to be you making these phone calls, doing Cover My Meds. Other people in your team can help with that. So we as APPs can be seeing, treating, and doing other things, though I think that's a really great point.
One other thing I want to throw out to the audience is we all often think of, well, we don't want to use anticholinergic agents in older people. I don't really like to use them in younger people because we know the effect is cumulative. So imagine if somebody is going to need therapy for years and years and years. I try to make that part of my argument in favor of using a beta-3 agonist. Now, I don't know that the person at the insurance company is listening to that argument, but if it was them or their child, they'd be listening to the argument.
That's a great point. I am just going through the chat a little bit more. We have noticed if our patients have GERD, the prior authorization for mirabegron has been approved. That's awesome. I didn't even know that. With industry coupons, patient assistance becomes an issue because those usually only go to 3 to 4 months. I know. Oh, and one other question that we didn't mention earlier, but we're on, when do you recommend taking beta-3 agonists? AM, PM, is there a certain time? Anyone?
Whatever time you want. I mean,
whatever time you'll remember it.
The same time every day-ish.
Yeah.
Whatever time you'll remember to take it.
Amen. Okay. Anything else to discuss? I just want to thank everyone so much. That concludes our panel discussion today. You may now go to the AUA University and claim CME credit. Thank you for joining us this evening. Don't forget to tune in to the next series of activities designed for APPs hosted by the AUA. Contemporary Management of MIBC and Beyond, Expert Guidance for APPs on December 9th at 7 p.m. Eastern, and Non-Muscular Invasive Bladder Cancer, Expert Guidance for APPs on December 12th, 2024 at 7 p.m. Eastern. Thank you so much. Have a great night.